Since 2015, Pop Health Podcast has brought to you some of the best minds in healthcare, including leaders from government, not-for-profit, and investor-backed powerhouses, as they share successes, failures, and how our audience can move forward in today's constantly evolving healthcare world. Thank you for joining us for today's episode presented by 24 Hour Home Care. Hello, everyone, and welcome to another episode of Pop Health Podcast. I'm Gavin Ward, host of Pop Health Podcast. In today's episode, I had a little bit of a treat as we had returning guest Charles Bacchi, who is the leader for the California Association of Health Plans, which all insurance organizations or health plans with a Knox-Keene license in California are a part of. In today's episode, Charles gives us a little bit of insight into his days as a soccer coach, but more importantly, talks about the work of CAHP, C-A-H-P, and how they advocate for the various health plans and health plan members here in the state of California. Charles will also give us a little bit of a heads up on their upcoming conference and how folks might want to participate. We hope you enjoyed today's episode. Feel free to check out other episodes of Pop Health Podcast by visiting us at pophealthpodcast.com, checking us out on our YouTube channel, or visiting us wherever you listen to your podcasts. Thanks, everybody. Enjoy today's episode. Charles, welcome back to the show.
Thanks, Gavin. It's great to see you again.
Yeah, great to see you as well. Folks, we're recording in July. We were just talking off the recording about the mild weather. Charles is up in the Sacramento area. I'm down in the LA area. So we're, I guess, midsummer now, Charles. Not too much heat. Have you been able to enjoy it with family or friends so far, or any vacation, anything like that?
No, I mean, it's been great. You know, I didn't have any huge vacations. We have a small one coming up, but it's been fun, and it's just been so nice to not be sweltering. I feel for the rest of the country, though, because this is one of the cooler summers we've had in California. I think all of our heat has gone elsewhere, and so I know it's tragic and difficult. So for all of you out there across the country, we're sorry for giving you our heat, but it is what it is.
Yeah. Thank you for acknowledging the rest of the country. Our show does have folks from outside the state, so that's a really nice acknowledgement and consideration, Charles. Before we jump into your organization, the upcoming conference, some of the things happening nationally and here in the state, we always like to kick off the shows, as you might recall, with a fun fact, hobby, something that might surprise the audience about you. So would you mind sharing something about you that could surprise the audience?
Yeah, I've used all my good material already. I've talked about growing up on Guam. I've talked about growing up on a cattle ranch. So I guess I'll just toss out there that, you know, for 3 or 4 years, I was a girls' youth soccer, rec soccer coach. Right. And that was an experience from like age 11 to 14. So I was right in that zone where you are watching kids grow up in front of you, and you're going from them doing cartwheels, you know, on the field to, you know, at the end, the boys team practicing nearby by the time we were done, coming over and flirting with the girls. And yeah, it was a really fun and humbling experience. And I kind of miss it a little bit, to be honest, but it was a good time in my life. So.
That's awesome. By any chance, was it American Youth Soccer Association, or was it just more the local, like, city league? Or
no, it was like the local city league, rec league, and it was very, you know, it was very hit and miss as far as quality went.
Yes,
and not too serious, right? I mean, although some of the parents took it seriously, you know, if you wanted to go play competitive soccer, you went off and played competitive soccer, and our girls did not do that. As my co-coach told me once, he said, we have a lot of incredibly talented girls on this team who also play soccer. We had track stars, volleyball stars, you know, gymnasts, artists, but, you know, they just happened to like to get together and play soccer. So it wasn't too serious.
I love that line. I don't know if I heard exactly that, but something like it. I gotta use that. That is awesome. I'm going to talk about soccer for another 60 seconds. I know that's not why you guys are here, but I'm the host, so I get that privilege. I love soccer. I'm a soccer coach, soccer referee. Curious, did you ever have to referee too, or just do the coaching?
No, you know, and I have to admit, Gavin, that a bad referee just drives me absolutely nuts. You know, if you've got to be decisive, and I tried not to yell at the referees, especially the youth referees who were reffing the games. You know, I was always very, very good, but every once in a while you'd get that guy who was just collecting a paycheck,
Yes.
And it would drive me nuts. We had this team that was our rivals, and so it always got very heated because we were always in first place and they were always in second place every single season. And our games were it actually got kind of bloody. People were getting wiped out.
Yeah, thanks for sharing, Charles. So a lot of our folks listen for the first time in our episodes. So many of them are returning listeners or watchers as well, or viewers. So some of the folks may have heard or seen you before, but can you give us a reminder about who CAHP is and your role within the organization?
Yeah, so CAHP stands for the California Association of Health Plans. We represent all of the Knox-Keene licensed health plans in the state of California. I think we have about 45 plans who provide coverage to around 28 million Californians. It's all the big national firms, plans that you've heard of: Aetna, Cigna, United, Anthem. But we also have California giants like Kaiser is based here in California, as well as Blue Shield of California. And then we represent all of the small local plans that are county-based and provide Medi-Cal in the state of California. So our main role is to advocate on behalf of our member plans at the legislature, at the governor's office, agency, as well as all the departments that regulate us. And I think we're up to 3 or 4 departments now who we have to touch. And so our job is to basically represent the interests of our members and try and keep healthcare affordable and high quality.
Yeah, that's great. So that's quite a few health plans that you are supporting. I think you said 45, approximately 45 was the give or take was the number. Is California? I don't know if you'll know this answer, but is California the state that has the most health plans to kind of get together, or are there other states that have maybe even more? If you happen to know.
Yeah, so we are. I don't know that we're the most. It wouldn't surprise me, but other large states, New York, Texas, California, of course we have, and Florida have a lot more health plans than most small states. But there are states in this country that only have 1 or 2 insurers or health plans in those states. And I talk to my colleagues in those states, and their job is very easy because they represent 2 health plans, whereas I have a wide array of viewpoints and perspectives from our members. But California's healthcare system is very unique in that there's so many people in it, including in our Medi-Cal system. We have 22 health plans doing Medi-Cal.
Yeah. And
so they basically, the state is divided up by counties and sometimes regions of counties, and so healthcare is really kind of has to be local. There's only 2 plans that offer coverage from Wairika all the way to the border with Mexico, and that's only 2 companies that can do that. And then everybody else, checkerboards the rest of the state. So.
Yeah, that makes a lot of sense. So because you're representing so many different health plans, it's probably difficult to please everybody, right? I think within CAHP you have your staff, but you also have, I believe, boards and committees, correct?
Yeah, so our board of directors is I think it's about right now it's a little low because we've had some retirements, which is a thing, but it's generally around 15 of those 45 plans sit on our board, and they're operational leaders. So these are plan presidents. In the case of the county plans, sometimes they're executive directors, but basically they're all running multi-billion-dollar companies, and they're great. We have tough conversations sometimes, but I think they show deference to each other, and they understand, I should say, that when we are together and united, we're much stronger, and that's when we get the results that are the best, is when we're united. So we try to really forge that consensus and bring the plans together into a shared viewpoint that can be really, really powerful.
Yeah, that makes a lot of sense. So when the state, I guess when policy or advocacy needs to be done with Department of Healthcare Services or different entities, is CAHP, do the plans leverage CAHP's strength and resources to approach Sacramento? Do they approach Sacramento themselves? A combination of the two? Like, how does that work?
Both. Yeah, both. I mean, each plan has got its own interests, and they have their own, they're unique. Like I said, some of them are just in some regions of the state. So issues that they're facing can be really kind of sort of personal to that plan. So what we're looking for is we're looking for areas that impact all of the plans, and that we can really advocate on behalf of all of the plans. So yeah, plans have their own governmental affairs people. They're up in Sacramento here, lobbying the departments, talking to them. Our job is to pull everybody together in a unified voice and find areas where there's, universal agreement, because the state doesn't want to create a law for one plan in one county or, two plans in two counties. They want to have statewide influence. And so that's really where we kind of come in to sort of bring it all together. And then my team, we have very frequent touches with the state regulators. So I would argue that we touch them more frequently than the plans do. And so, part of our job is also to collect information, know what's coming, what the timeline is, the calendar, what some of the key issues are, and telling the plans ahead of time. And, the people who work on our plans are busy people. They're trying to provide healthcare to millions and millions of Californians and deal with their provider networks and all the emerging stuff that's happening in our healthcare system. So it's kind of our job to relieve them of some of that burden, right? Of like having to be on, a weekly 1 hour long call with the department going over a to-do list. That's our job, and then we, help provide that to our members. And that's the benefit that we provide. And that's why people join us. So
that's great. And it sounds like whatever you're doing is working, since you mentioned so many folks are a part of your association. So you mentioned you wanted commonalities with your efforts, right? That would affect all the plans or most of the plans. So can you tell us this year in 2025, we're heading into the second half, or we're in the second half of the year. What are some of the initiatives of CAHP? What are things that are either happening today or on the radar?
Yeah, I mean, it's one of the things that all of the health plans do. In fact, it's something that even the government does is, we use utilization management tools to ensure that the healthcare that's provided to our enrollees is the highest quality. It's the right treatment, and that we're not wasting a bunch of money on things that don't work and or are being done on the wrong person for the wrong condition. So, we're really spending a lot of time trying to explain to policymakers the importance of things like prior authorization, which we know is annoying to our friends in the provider community. So for those of you who are listening to this podcast, I hear your pain. We know that prior authorization can sometimes be burdensome and sometimes it's used too much. But our industry is going through a whole reexamination of this and looking at ways to make this better. And we think that if we can get the providers to use more electronic submissions for their claims, that we are going to be able to approve them much faster. We can reduce a lot of friction there. Yeah. So we're trying to educate policymakers, but the industry is also going through a self-examination to try and improve this process. But in the meantime, there's still a lot of proposals in the California legislature that would, restrict our ability to use prior authorization, sort of in ways that just make it more difficult to do our job. And there's, it's popular. People hear, red tape. They hear about, maybe they had an experience themselves where something that they were prescribed, they had to wait until authorization was given. Providers hate filling out the paperwork, but it's really a necessary part of our healthcare system. Without it, really bad things can happen.
Yeah.
Not just on the healthcare outcomes, but just also on the financial side. And so it's interesting because as our state budget is going through a really rough patch, policymakers are looking for ways for the state of California to save money and to do a better job. And they've identified areas in our healthcare system in California where they're not using prior authorization and bad things are happening. For example,
sorry, Charles, sorry to interrupt.
Yeah.
So, you and I, we're in the healthcare world on a daily basis. The word prior auth is known by many, but not necessarily by all of our listeners and viewers. Could you loosely define what prior authorization means?
Yeah. So, when you go into the doctor's office and you are seeing your doctor, no big deal, right? Your doctor's going to send us a claim. We're going to pay for the visit, etc.
Yeah.
But let's say your doctor refers you for an MRI, which costs a few $1,000s. Well, we're going to want to know, like, what's that MRI for, and does it make sense? And so we might, not all plans would necessarily, but we might say to the doctor, before you're allowed to have this MRI, we need to know what the healthcare condition is of this person. What are you trying to treat? And then we as health plans will review that and say, well, is this something that an MRI is given to, normally done? And then we will approve it, and then the patient can receive the MRI. And so it's designed to that's a situation where sometimes there's a lot of overuse of imaging devices and machines, which can lead to overexposure to the patients because they're not completely safe. But providers sometimes have an incentive to use the MRI machine as much as possible to pay off their investment in it. And so we're just trying to keep track of what's going on and make sure that it makes sense from a medical perspective, and then we approve it. Health plans approve almost all prior authorizations, a very small percentage that don't get approved. But that really annoys people when it happens because we handle a billion claims a year here in California. So, even 1% is a lot of claims. So anyhow, but the state of California even is now implementing prior authorization on some of the programs they run that are outside of the health plans, because there's so much fraud and abuse, there's waste, there's people misprescribing drugs. So we think policymakers understand it's important, but we just have to educate the public and do a better job explaining to people why it's important for us.
Yes, that's a really good point. So just to play that back on the prior authorization, the MRI example that you used means instead of just go ahead and getting the MRI, and it's kind of like always approved, right? You don't have to get there's not another step before you go in. The prior auth means there is that extra step where you have to wait to be authorized, and that's what prior auth is.
Yes.
So would an example of non-prior auth be like my physical that I get once a year? I just walk in, I schedule it. It's part of my insurance policy that I get a physical once a year. I don't need another layer of approval. Yeah,
generally it's where complex care starts to happen, and the health plan wants to know what's going on. And in some cases, we don't know that Gavin went in for his physical, right? Until we receive a claim, right, from the provider, and they're like, oh, Gavin went in to see his provider and he got a physical. Well, if the next appointment we see on your deal is, Gavin's been prescribed or has been referred to someone for an X-ray or an MRI or whatever, and we're like, well, what's going on with Gavin? Like, we don't know what's happening with Gavin, and so we're going to ask, well, what's happening here? And they're like, oh, well, we think Gavin has cancer. We're like, oh, that's good for us to know too. And so yes, we approve, his imaging test. And then that allows us to kind of start doing complex care and everything. So it really is integral to like what we're all doing here. And for doctors, they don't like to fill out the paperwork and they get annoyed having to justify themselves. And so we all have to do a better job. But it is a big issue this year. It's taken a lot of time of our time, and hopefully we'll be able to end the year in a good place. So.
That's good to know. So the prior auth issue, is that across all plans, whether it's Medi-Cal, Medicare, commercial, kind of across the board?
Yep. Okay. It is a consensus issue. Yeah.
Okay. Got it. So I know when we were talking ahead of the show, there's not just like this prior auth issue, but there's a lot of other things happening across the country that can impact California as well. Would you mind talking or sharing a little bit more about that?
Yeah, this has been a challenging year, with what's been happening both at the state level and what's been happening at the federal level, which has been in the news, obviously quite a bit. And that federal action on HR 1 or the budget reconciliation bill has really some long-term impacts on the state of California that are going to kind of roll out over the next few years. One of the most immediate is the way that it changes Medicaid financing in the states. California is a state that uses what are called provider taxes. Somewhat complicated, but the general idea is our providers have agreed to tax themselves. The revenue from the tax on themselves is sent to the federal government, who matches it and then sends it back to us. And HR 1 limited the ability of states to use provider taxes, and California uses a lot of them. So especially for our hospitals, who really depend on billions and billions of dollars annually in their hospital fee program. And that's going to have to all be redone and reduced. And so California is looking from the perspective of at the federal level, receiving a lot less money from the federal government, which means the state has to go kind of more and more on its own in financing our healthcare system. And what we saw this year in the state budget is that the state is now realizing they can't fund our current program and have a balanced budget. And so some really tough decisions were made here at the state level. They reinstituted an asset test on Medi-Cal enrollees, which had been removed, which meant anyone could apply for Medi-Cal no matter how much money they had in the bank. That's been reinstated here in California. The governor excluded coverage for GLP-1 drugs in Medi-Cal, which is going to save, they estimate, almost $700 million in 28 and 29. They have frozen enrollment into our program that provides Medi-Cal coverage to undocumented individuals. So that's now frozen. That program's frozen. It's turned out to be very, very expensive, much more expensive than the state anticipated, and it's funded 100% with state dollars. And they're going to start charging for those undocumented Californians a monthly premium of $100, of $30 a month. So that's an example of, like, you've got the federal actions kind of dumping the responsibility onto the states to fund their healthcare program, but yet the state is already struggling, even without those changes in funding, to fund our program. So this is a time of scarcity, and it's going to be a time for our health plans where they're going to have to tighten their belts. There's going to be less people covered, and there's going to be less funding for healthcare, and that means we're all going to have to work together to try and continue to provide high quality care to our enrollees, both those who get it through their employer on their own, or who are on Medi-Cal.
That makes a lot of sense. I appreciate the explanation. Just to clarify on the folks that are currently undocumented, you mentioned that they're freezing the ability to, or I guess freezing enrollment. Do you know that if you don't have the actual date, no worries on that, but I believe that's coming up, not necessarily in place. And again, if you don't know.
Yeah, I think it's January, Gavin. Okay. I'm pretty sure it's January. And, we've already seen with the immigration raids here in California, we're already seeing, as you know, from LA, where it's the epicenter, right, of some of those raids. We're seeing evidence that in areas where raids are happening frequently, that the undocumented population is not going in for healthcare services because they're concerned for their safety. They're concerned that they're going to get intercepted, right, outside of the doctor's office. And so, this is really going to be a very challenging thing. For those of you in other states that don't have the levels of undocumented folks that California does, this doesn't seem like a big deal, but there are millions and millions of Californians who living in this state who are undocumented, and they work all over the place. They do incredible things to keep our state running. So, the fact that they're not going in to see medical care is likely going to end up in more hospitalization visits down the road.
Yeah.
And that's going to be way more expensive than if we could have just provided them health care, at their local clinic. That's something that's going to kind of be a result of this. But yeah, in the meantime, that freeze is coming up. And so the program is, I think the goal for the governor is to shrink the number of people on that program because the state just can't afford it right now. So it's unfortunate.
Yeah, that makes sense. State's been and wants to be generous but at some point it's just it's impossible to do everything. So good points. One thing I just want to reference before we hop off the undocumented workers is it sounds like the folks who are already enrolled, if they can manage the small monthly copay, and then when I say small, forgive me, it may not be small for them.
Yeah.
But I think just the way I interpret it is, hey, if there's a way to just get a little bit and be able to maintain the coverage, they can still benefit while also the state can help the state a little bit. So it sounds like there's a finesse job that they're trying to do. It's very difficult.
Yeah, no, I mean, the governor originally proposed $100 a month in premiums, which would have been, which I think a lot of people would have struggled to pay.
Yeah.
$30 is what the legislature and the governor agreed to in negotiations. It's a lot, but it's not, it's, for healthcare, I mean, I think, it's unfortunate, but I think you can see that it's necessary, and it's better to do that than to just, end the program.
Yeah.
So, we'll sort of see how it goes in future budget years. We'll see how the economy does here in California. And we have a very boom and bust economy here. It's like 1 or 2 years we're flush with cash. 1 or 2 years we're completely broke. And so, I don't envy the people at the Department of Finance in having to try and navigate all that. So
it's funny you mentioned you don't envy those folks making the very difficult decision. I was literally about to say, I don't envy the leaders in our state who are having to make, like the governor and others who are having to make these very difficult decisions. I have a group of friends who are super smart guys. And when they complain about policy, I say, hey, why don't you run for office? And I'd literally vote for, I think they would actually potentially do a good job, but they don't want that stress and that headache.
I mean, everybody thinks it's a glorious job, but it comes with a real cost. And I worked in the legislature for over, I guess it was a little less than a decade. I guess I worked there for 8 years. And so I got to see firsthand what it's like to be a candidate and a legislator. And it's cool, but it doesn't pay that well.
Yeah.
And you have to put up with a lot of people hating on you. And in today's world, unfortunately, people have lost their filters coming out of COVID. And so a lot of electeds that I talk to, some of whom have gone back to become city council members, in their local town. And they tell me that their city council meetings are a disaster, that it's just people coming in, threatening them. They have to have police in the meetings now. They have to limit testimony because people just show up and they just act out and act crazy. And it's just really, really difficult. So, we didn't need to go down that path. But yes, it is a tough job. And as much as we like to make fun of them or mock elected officials, they are important and they do have to make tough decisions. So, and our job is to influence them, right? I mean, that's the essence of CAHP's existence, is we have to change their minds to get them to do things that make sense for our healthcare system.
Yeah, makes a lot of sense. So you mentioned earlier, California Association of Health Plans, it's pretty much all the health plans in the state are your members. Are there other folks who are a part of CAHP, or for example, I've been to CAHP seminars, I've supported CAHP by attending events and doing sponsorships, but how else do people get involved with CAHP?
Yeah, so our health plan members, you need to have a Knox-Keene license, but not everyone has one. So we also provide membership for health groups. These are groups that have a partial license. So if you're a hospital system or a medical group, you can join as a partner member of CAHP. And then we also have associate members, and associate members are basically companies that work with health plans or want to work with health plans. They join CAHP to get discounts to our events. They get to receive some of our emails and information about what's happening in California, which actually is our weekly email that goes out every Friday is literally a roadmap to everything that's happening in healthcare in California, if you stop and take the time to read it. And then we hold events multiple times a year. We have, right now we're doing 3 annual one-day seminars in Southern California, which I got to see you at, I think, earlier this year. Gavin, it was good to see you, where we tackle a topic and we bring health plans together with our associate members as well as others who want to attend and learn about what's important in California. And then, of course, members get discounts on sponsoring our conference attendance, free tickets to our conference. That's all kind of part of being a member of the California Association of Health Plans.
All right, awesome. So, and I've attended, like you mentioned, some of the seminars and the annual conference. They're great events. Shout out again. I always like to do this every year to Marjorie King, who helps put those on. So shout out to her and whoever supports her there. The upcoming conference is a little bit earlier, still in the fall technically, but pretty close to summer in Palm Desert at the great JW Marriott Resort there. So a couple questions on the conference. I'm guessing, I don't know if because typically it's in October, right? Towards the end, what's a little cooler. This time it's a little bit closer to the summer. I'm curious about the movement of dates and if you can share a little bit more about the conference.
Yeah, it's the movement of dates is really a result of the way how hard it is to get a hotel resort reserved, because when we go into that property in Palm Desert, we kind of own the resort.
Yeah.
We have all of the spaces taken down for us. The restaurants are all booked out. The rooms are all sold out. And it is CAHP's conference. And so to find a facility that can do that for 1,200 people for 3 days or 2.5 days, sometimes the scheduling dates don't work out, and we have to schedule 5 years out to reserve it. So I would have to go back in time to 5 years ago to remember why it is we got this date, but I'm pretty sure it was that we couldn't get the block that we wanted in October. It was already sold out, and so we'll be back to our regularly scheduled program next year.
Okay.
And then I think the year after that we'll take a brief pause and go to San Diego for a year, and then back out to the desert. So. But it's a great facility, as you know. I mean, it's a resort. It's got a golf course, massive pools, indoor lake, and it's just a really, really fun location for everybody. And it's everything CAHP, and we really do love that property. Happy to be going back there and happy for our conference, which, as you noted, is coming up really fast. For Marjorie and I, this has been a challenge to us. Because we lost a month of planning. Yeah. And so we've had to speed everything up by 4 weeks, and it has been it has been difficult. Let's just say that. So, but we're going to pull it off, and it's going to be a great event.
Yeah. Okay. So tell us about it. I know I've been there plenty of years. I'll be there again this year. For folks who aren't familiar with it, who's coming? Who are the speakers? What are the benefits of attending?
Yeah. So, we have health plan staff will be there, health plan leaders, presidents, CEOs, as well as their government affairs people, their compliance, legal teams, network teams, medical directors will be there in attendance. We obviously have our sponsors and associate members who will also be there, either speaking, but most likely networking with the health plans. And then we get a decent number of providers, whether it's people who provide drugs or doctors, medical groups, hospital systems. We'll have a smattering of those folks in the audience as well. So it's kind of a smorgasbord of people. The energy is really great. There's a ton of networking that goes on. There's a ton of business that gets done. A lot of the plans are renting rooms and having team meetings while they're there. They're scheduling meetings with companies that they want to do business with. So it's a really good feeling when you walk around and you see everybody talking, having a great time, but also getting a little bit of business done. So this year, our keynote speakers are going to be focused on two things that are important. One is how to negotiate better, which is needed because we have less resources. So we're all going to have to negotiate with each other to divide up a smaller pie. And then we have on the second day, our keynote speaker will be talking about crisis management, which obviously in our healthcare system, there's a lot of crises. Yeah. So I'm looking forward to that. We also have the Department of Healthcare Services Director speaking about the future of the Medi-Cal program in light of all of the federal action and state reductions in funding. We have a couple of our medical directors are going to be taking the stage to talk about what they're seeing in coverage and trends that are notable for providing healthcare to our members. We're going to do a deep dive into street medicine in the Medi-Cal program for the homeless population. And we'll have a couple of speakers talking about federal healthcare changes, and how they impact California. So, it's going to be it's a great agenda. I think people will come away from it knowing more than they did when they got there, and hopefully will take away some things that will help them improve their lives and their jobs.
Yeah, no, absolutely. I agree. I've attended a lot of the sessions in the past. Do you know for sponsorships? I know those typically sell out. I have a lot of folks that listen in are providers and may want to sponsor or be interested. I know Marjorie's the go-to there, but do you happen to know if that's all sold out or if there's still spaces available?
I have not gotten a report this week, but I believe we sold out the sponsors on the floor for the exhibit hall. I think there may be a couple left. People can also do other sponsorships, but those are selling out really, really fast. So if you are interested in sponsoring, you should probably reach out to Marjorie King on our staff. You can find all the information about the conference at www.calhealthplans.org. And you can find links there. You can find contact information for Marjorie. We do accept, we also just have attendees. Yep. So we'll be selling, attendance all the way up until the day of the conference. But I do recommend that if you want to come, you should buy your ticket early and try to get in on our hotel block, because that also sells out. And the resort, if you're outside of our block, the resort charges full freight plus, and so it can be really expensive. So if you want to be on the property and get the most out of it, it's best to get your sponsorship in now, buy your ticket, and try to get in our hotel block. So.
Yes, I've had friends miss out on that, or industry friends that do attend miss out on the hotel block, and they've had to stay outside. So a little more inconvenience when doing that. So good point. Charles, we've talked about a lot today. I want to make sure before we wrap up, if there's any other initiatives, any key things you wanted to discuss today before we wrap up.
No, I just want to say to everybody out there, this is a trying time in our healthcare system, and it's only going to get worse over the next couple of years because when you have less funding, we all have to make tough decisions. And I think, we all need to work together, whether you're a provider, whether you're someone who is providing services to enrollees, or you're providing services to a plan, or you're a hospital, or you're a health plan. We've got to figure out a way to do a lot with less money. And so we just all have to work together. And I know it's going to be tough, but if we can, like CAHP, work together to find consensus around things that make sense and ways to improve our healthcare system, this is going to be a period where we're just going to have to do that. And I think it's the sooner people get that mindset, I think the better we will be as a state and as a country. And I appreciate you for inviting me, and of course 24-hour home care for sponsoring and participating in our events. So thank you very much.
Yeah, Charles, really appreciate it. It's our privilege to support the podcast and you guys as well. So I think that's it. I'm checking my notes here. I think I covered everything. I got another set of notes up here. I think we have everything covered. So yeah, Charles, really appreciate it. Appreciate Mary Ellen helping make this happen, and Marjorie as well. So we will see you in about 2 months, Charles, in the Palm Desert area. We'll see you there.
Awesome. See you there.
Thanks everyone for tuning in to another episode of Pop Health Podcast. We hope you've enjoyed today's episode, and if you have and want to check out other episodes, visit us at pophealthpodcast.com, iTunes or Apple Music, Spotify, Stitcher, and now YouTube as well. Take care.